Okay, so I'm Ellie. Nice to meet you again. Thank you for taking your time to sit with me and have this conversation. I'm kind of going to start and introduce myself a little bit, and then I'll ask you to introduce yourself. So, like I said, my name is Ellie. I am currently a level 1 master's student at North Central College in Naperville, Illinois. Um, I am doing this topic on concussion because I have a true passion for concussion, and I know there's a lot of people in the AT world who also have the true passion. So I'm excited to kind of have this conversation. And currently, I'm doing my clinical rotation at St. Francis High School. And my preceptor is also a fellow concussion passionate researcher. So this is great. So, yeah, go ahead and introduce yourself.
Yeah, I am Dr. Tamara McLeod. I am the chair of the Department of Athletic Training at AT Still University, and I oversee our post-professional masters in athletic training, a post-professional doctor of athletic training program, and several graduate certificate programs, including one in sport neurology and concussion.
Love that. Okay, so I'm just going to kind of start this with just a general overview of concussion, sports related concussion. So, the first thing that I wanted to talk about was just basically like what is a concussion and what are some of the signs and symptoms that we should be looking for.
Sure. Simply put, a concussion is a brain injury. We tend to think of it more though as a functional brain injury. So we don't see structural issues on imaging like an MRI or a CT scan. But what we notice is that the messages within the brain are slowed down, our ability to process and think and reaction time is all affected by a concussion. And when I'm speaking with parents and athletes, I often describe it as, we're used to, being in a world now where our phones run on 5G, everything loads very
Hmm.
fast. And think about a concussion as, now you're kind of in an area where if you're scrolling through Instagram, all the boxes just look gray. Nothing's loading. You've kind of lost a lot of your bars. And so that's, I think, really a good analogy of it's a functional brain injury, but it is still a brain injury, and as such, we need to, treat it carefully and make sure that we're doing the right things for our patients.
For sure. I like the analogy you use. I've definitely feel like it's hard to explain to parents that when their student athlete gets concussion, there's not that like structural damage all the time. It's more of that functional. So I like that analogy.
Yeah, and I think the other piece of that, and you're asking about symptoms, and there can be a whole variety of symptoms, but you might
Hmm.
have three patients, and what they're going to report from a symptom standpoint could be completely different. So there's
Right.
obviously the physical symptoms, the headache, the dizziness, visual dysfunction. There's cognitive symptoms like not being able to remember, feeling slowed down, feeling kind of like you're in a fog or foggy. There's some sleep related issues that we might see later on after the injury, and it could be, not being able to fall asleep. It could be waking up during the night. It could be sleeping all the time.
Hmm.
And then lastly, which I know is kind of your focus area, are those affective or emotional type symptoms that we can
Hmm.
also see. So I think because concussion it's very different, right? If a patient tears their ACL, we can talk about exactly what is going on, what
Right.
is torn, how it's going to get fixed. But with concussion, there's so many different clinical presentations that patients can have that makes it a very challenging injury to manage.
Yeah, for sure. Kind of going off of that, as an athletic trainer, normally we are the first people who are doing the evaluation process and considering the treatment and the continuation. So, what are some of the assessments that we could be doing for concussions?
Yeah, so I think and the way that I often teach this is we have kind of a whole number of different assessments that we can use, but what we pick from each of those buckets should really depend on what our goal is of that evaluation. So, for example, in our multifactorial assessment, we often use a symptom inventory. We often
Hmm.
use some kind of cognitive assessment, some kind of ocular motor assessment, some kind of balance assessment. But the ones that I would choose to use are going to vary by the time point and what I want to get from my evaluation. So if I am covering an event and something is happening on the sideline, my goal with my evaluation right there is to make a go, no go decision. Do I suspect that this is a concussion, that I need to remove this athlete? Um, or do I think the symptoms could be caused by something else, and I would do an evaluation to almost rule out concussion. Once a concussion is diagnosed, and I'm doing a follow up, maybe 24 hours to a week later, I'm going to use different tools because what we have, the sensitivity and specificity of those tools will vary. So, for example,
Hmm.
on the sideline, if I am trying to determine if I suspect a concussion, I don't necessarily care how many errors a patient has on a
Right.
balance error scoring system. I want to know, are they falling over or not falling over?
Yeah.
So my what I choose to use for a balance assessment might be very different. Same thing from a cognitive standpoint. I might just have them do a 3-word memory, repeat some things back to me, see if they remember my name after the evaluation. Whereas computerized neurocognitive testing might be used, day 7, day 8, when now I'm starting to think about returning an individual to activity. So we have so many tools at our disposal right now, which is good. I
Hmm.
think the art of practicing as an athletic trainer and assessing concussion is understanding which tool to use when, and more importantly, what information do you want to get that you can then use in your plan of care.
So kind of going off of like the computerized testing that we have, like impact and sway, do you see a benefit in the everyday symptom? Like I know on Sway, you go in every day and you like type in your symptoms and you kind of it gives you a score at the end. Do you see a benefit from that doing it every day, or should we be kind of spacing it out more?
I actually think it could be detrimental to do it every day.
Hmm.
I think we need to check in with our patients every day, but to have them fixate on a specific symptom list and try to quantify
Hmm.
how they feel every day can actually, I think, result in some mental health considerations down the road
For
because now
sure.
they are so fixated on these symptoms. So I would suggest, obviously, 24 hours post injury, we want to get a sense of where our patient is. And at that point, should we be thinking about some academic adjustments if they're a high school or a collegiate athlete? So we need to get a good, robust symptom inventory. So I think sitting down with them and walking through a symptom inventory like you would see in Sway or the SCAT tools
Hmm.
is appropriate. I don't think it's appropriate to just hand the patient a paper and say, fill this out. Working with adolescents myself, they don't understand what all of those
Right.
words mean. I've
Hmm.
had a lot like, what's irritability? So it's better to have a conversation with your patient. Um, and I also think it's better to actually lead, like, tell me what symptoms you're having. And then, well, I have a bit of a headache. Okay, well, if you had to rate your headache on a scale from 1 being a mild headache to 6 being a severe headache, how would you
Hmm.
rate it? And then let them continue. Then you can fill in the blanks. You haven't really talked about sleep at all. Have you had any issues with sleep? And you can kind of go
Right.
back and fill in those other ones. Um, I think on the next day, it's, hey, how are you feeling today compared to yesterday? Are you better, worse, the same? And you can kind of get that sense. I would probably say for a formal symptom inventory, maybe every 4 days. I like to use patient report outcome measures as well to
Hmm.
dive deeper. I think we also need to remember with any of those symptom screens, they're a screen. They're kind
Right.
of that first step, right? So if the patient says, well, I'm dizzy, and I think I'd probably rate my dizziness as a 3. And if all you do is say, okay, you're missing a lot because dizziness can really feel and be something that's different for everyone.
Hmm.
Some people it might be vertigo, the room is spinning. Other people might see it as a motion sensitivity issue, like they have trouble walking down the halls. All of that stimuli starts to increase symptoms. And so, if a patient has dizziness, I should be asking follow up questions. Tell me what you mean by dizziness. Is it constant or does it come and go? What aggravates it? What makes it better? And that's going to help, I think, drive your plan of care and what you're going to do with
Hmm.
your patient.
For sure. So, kind of going along symptoms, obviously everyone's recovery is different. But when do we start to worry and refer out to someone else?
So I think it depends on the patient a little bit and their past medical history. I
Mhm.
would probably be more apt to refer quickly if I have a patient who has a number of prior concussions,
Right.
because I know from the get-go that they're probably going to take longer to recover. The general consensus from the Berlin meeting was adults are about 10 to 14 days, and children and adolescents are 3 to 4 weeks. So we have to have those honest conversations with parents
Mhm.
that it could take 3 weeks for your child to feel better. Some of the data that was presented in the Amsterdam meeting in the fall suggested average symptom resolution time for those in the 13 to 18-year-old age range was 16 and a half days. Those that were older than 18, it was about 10 days. Full return to sport in adolescents is about 20 days, and it's about 17 days in adults. And that was from their compilation in the systematic review that
Mhm.
was put together that will helping to support the forthcoming Amsterdam concussion recommendations.
So, when we are starting that return process, do you find it hard to educate and let the patients know like the benefits of the return to learn and then the return to play? Because I feel like a lot of athletes are like, let's go, I just want to play, I just want to play. But educating and telling them the benefits and the risks of not going through that return to learn, return to play. So, kind of how do you go about that?
Yeah, patient education is critical. And for adolescents, parent education is critical.
Hmm.
I think there still is a lot of misconception about concussion in the general public.
Right.
I've spoken with athletic trainers and they tell me horror stories. Well, the parents don't believe concussion exists.
Hmm.
That is an uphill battle. That is, really, really difficult, I think, to try to manage. So I think it's important, and how we've approached concussion has certainly changed even in the last 3 to 4 years. The current NATA position statement, which I am a co-author on, still suggests rest until asymptomatic, then start a return to play progression. I
Hmm.
will say that we are in the process of updating that. We are on a hold until the Amsterdam documents are published, and the new return to play progression is kind of we need published from them that we can then simulate and have in our document. But I think what we need to do is be educating patients that your recovery starts on day one.
Right.
And that initial rest, that 24 to 48 hours, that's part of your recovery. Your brain needs some time to heal. But
Mhm.
then we need to get you active. And so the kind of return to play progression from the Berlin statement, stage one is subthreshold aerobic exercise. That can be started as early as day 2, day 3 post injury. There's some evidence to show that the sooner we get patients active, the better they do.
Mhm.
And that activity, it also needs to be moderated and we need to educate patients. It's not, you can go do everything. It's, we're going to
Right.
let you walk on a treadmill for 15 minutes today,
Mhm.
but at least it's moving forward. I think it's also important to highlight to patients that as far as more of the preseason education, that when we identify concussion earlier, when we remove patients from play earlier, they get back to play faster. Those
Right.
that try to hide symptoms, it takes them longer. So the early recognition, early removal, and early referral to athletic training or other healthcare specialties is actually going to be better for patients. And so part of the recovery and the education is we want to get you back to what you can do as soon as we can without making your symptoms worse. And that
Mhm.
involves going back to school, but having communication with teachers that the teachers might need
Right.
to make some changes in the classroom to help the student be there, because it's more beneficial for the student to even just be sitting in the classroom,
Mhm.
listening and engaging than being home.
Yeah, I feel like that's definitely something that not a lot of people realize, especially parents. I feel like once they hear that their child has a concussion, they want to pull them from school for days and days and just put them in a dark room and sleep for hours and hours. And it's like, no, we need to get you moving. We need to
Yep.
start this process. So,
Yep.
um, kind of going into the mental health aspect of things, we when an athlete has multiple concussions, what are some of the like mental health risks that we're putting through the patient?
Yeah, I'm not sure we know specifically. I
Yeah.
think what we do know is that once an individual has a concussion, they're more apt to sustain subsequent concussions. We also know that individuals who have pre-existing mental health conditions tend to take longer to recover, and that even family mental health conditions can also have an
Mhm.
impact as a risk factor for a prolonged recovery. So I think what we should be monitoring mental health almost in all of our patients, concussion or orthopedic injury, because I think we can look at everything from the isolation in some cases that we still see with concussion, unfortunately, like not being in school, not being around their team, can actually impact recovery. And I've done qualitative studies where we've interviewed these young adolescent athletes, and they talk about how they felt isolated, and then they tried to minimize their symptoms because they wanted to feel normal.
Mhm.
So we need to actually normalize that, it is a concussion and there could be mental health concerns. But we're going to assess you, we're going to monitor you. I think we need to do a better job of using patient outcome measures specific for mood disorder, anxiety, depression. um, I think we need to be open to having referral sources, the school counselor, a community psychologist, others being part of our concussion management team, and hopefully just reduce the stigma that mental health is a problem.
Yeah. So, going along the lines of how we want to keep those athletes who have a concussion moving, if they get to the point where they're feeling that isolation, they're not motivated, they're depressed, they have anxiety, how do we go about motivating those patients?
Yeah, I think that's where we could probably, start to think about their social support network, and getting them doing something with the team and the teammates. The whole, being away from the team, it can be problematic. I mean, you've got these individuals who have a number of symptoms from the concussion. They're also probably now worried about losing their spot on the team. They're, in some cases being told not to do a bunch of stuff. And so we really want to try to get them into a normal routine. And maybe instead of having them walk on a treadmill, it's like, we're going to have you walk around the soccer field
Mhm.
and two of your teammates are going to walk with you instead of doing the warm up that everyone else is doing, so they can have those conversations. If the team is sitting in a circle stretching or doing something, having them do as much as they possibly can to not miss out on the inside jokes, the conversation, all of the things that we know happens in sports that is
Mhm.
actually so beneficial to just social, emotional, psychological development, not taking that away. If we do notice that, the patients aren't motivated, I think we need to try to get at why. And we can do the best we can as ATs, but at some point we might need to have a mental health professional involved that might have to work
Mhm.
through. Maybe it's fear of re-injury, that can be common with a lot of sports. Maybe there's other reasons. Maybe it's parental pressure. They don't even really want to be playing. This is a great excuse for them to stop. It's really digging in and trying to figure out, are there some other reasons, why they're not motivated or why they're not recovering, and then what can we do to help them? Again, I think if we think of our patients as a person
Mhm.
first and an athlete second, it really helps with that kind of mentality and that patient-centered care philosophy.
So, for those patients who have current or past mental health conditions and they're say for preseason, we want to educate them on the risks of those symptoms, the mental health symptoms coming back or being reproduced. How do we go about that conversation?
Yeah, I think I would try to approach it more at a global level and less at a individual level,
Mhm.
because I think sometimes then the athlete might feel like they're being called out. But
Yeah.
number one, on our pre-participation physical exams, we should be getting some kind of mental health status. I know the new monograph and what we use in Arizona for our high school athletes now. We have the PHQ-4, which is 2 anxiety questions and 2 depression questions. And if they score a 3 or a 4, it's highlighted. It is not exclusionary from participation. It's just more of a, hey, kind of keep your eye on this. And I would not be surprised if a good number of adolescents, with everything that's been going on from pandemic to just the increase in general recognition of mental health issues, that they're scoring that. I think when we're doing our preseason concussion education, we have to talk about the potential for, it's a physical injury, but there's also it's a mental injury, it's a psychological injury, and these are some things that you might not think of being associated with concussion, but you might feel more anxious, you might feel more depressed, you might have some sleep issues. And that's why it's so important that you tell your athletic trainer if you're having any of those symptoms. So just more that global education, and always following it up with, and if you do have a concussion, this is how we are going to help you recover. So that there's that positive spin on it, that it's not just, we're going to pull you out and
Yeah.
that's it.
Yeah.
That we really have, there's a plan in place because we want to take care of you as a person.
Does having those past mental health conditions or current affect the recovery time of concussion?
There's some evidence to suggest that individuals who have a history of mood disorders might actually perform differently on even baseline
Mhm.
concussion assessments, and then may also have a different recovery trajectory. I don't know that we have conclusive evidence, but mental health, pre-existing mental health conditions are certainly a risk factor for a longer recovery.
So with those baseline tests, how do we, if they are not performing as well as they would if they didn't have those mood disorders, and then we compare that to the concussion, how does that kind of go about?
Well, I mean, if you're doing a preseason baseline, so you actually have their own individual data,
Mhm.
uh, y- their post concussion should probably be a good It should be a good comparator. I think where it might become a little bit more problematic is if you're using like age appropriate normative data, because we don't have normed data that separates by any and all
Mhm.
mental health condition that we might have. And it's primarily symptoms. I think those that have pre-existing mental health conditions consistently demonstrate higher symptom scores at baseline compared to those who don't. On the balance and the neurocognitive component, the literature is a little muddy, so it's not, super consistent either way. But like any other risk factor, right? Being a
Yeah.
female, your age, all sorts of your past concussion history, it's something that the clinician just needs to take into consideration when they're making decisions and determining how to handle and how to care for this patient.
So when we're treating concussions and we want to kind of avoid those patients having, I know we can't like prevent mental health signs like symptoms, but what are some of treatment options that we can do to maybe like minimize their risk?
Yeah, so I think as an athletic trainer, what we can do within our scope is listen, right? We can listen to our patients. We can make sure that we're asking them follow-up questions. How are they feeling? Do they have any concerns? How do they feel like they're doing in school? Can we help with the communication with the teachers? Once we kind of get beyond some of that, I think that's where we need to know, at what point do we have to refer, and
Mhm.
who do we have available to refer? Most, Power Five, Division One colleges have psychologists in-house in the athletic department
Mhm.
now. Other level institutions could be less resourced, but you can always consider who is in your Office of Disability Services. Most institutions, collegiate institutions, have some kind of access to mental health professionals through student health. It is
Yeah.
as an athletic trainer, going to meet those people, saying, hey, you want to meet me for coffee? I'm so and so. I'm, the athletic trainer here. We might have student athletes that we're going to need to refer to you down the road. That kind of, again, preemptively. The high school setting is going to be a little bit different.
Mhm.
I've learned counselor in the high school world means many different things.
Yes.
It could be a guidance counselor, right, who's
Right.
very helpful with scheduling in colleges, much less so with actual mental health concerns.
Mhm.
Some high schools have access to a psychologist, or might have a district psychologist available. And then I think we need to think a little bit of other healthcare professionals that may be at the school that actually have some cognitive and psychological components in their scope. Speech language pathologists, occupational therapists, they might be able to do more than the athletic trainer can, and might, those are some healthcare professionals that are
Mhm.
often associated with a district, if not at a particular school. And then it's the community. Is there a psychologist, psychiatrist, counselor, someone available in the community? And I think for someone maybe moving to a new place or who's not familiar, most states have either a brain injury association or a brain injury alliance.
Mhm.
At the national level, we have two different organizations. Reach out to them and see who they use for their moderate to severe TBIs, and maybe there's some people in your community that would absolutely love to be a referral source for or be involved with the school.
Going along the lines of, um, like, reaching out for those resources and seeing those, counselors and psychologists and all those things. I know there's a lot of stigma behind reaching out to those types of providers. So how do you think, as an athletic trainer, we can educate patients and parents on the benefits of going through those processes?
Yeah, education is always tough. I think it becomes, having a message that, these individuals can actually help with recovery. They have strategies and, can work with you on developing skills
Mhm.
to help you manage the injury,
Right.
just like you might go to a physical therapist, for an orthopedic injury. um, I would really hope that, at least over the last several years, that the general perception of mental health, issues in athletics has changed a little bit with Simone Biles, Michael Phelps,
Mhm.
Naomi Osaka, like all of these high profile athletes being very open with some of their struggles, that, people would be less resistant, to have that as a referral source. I also think, from a coach standpoint, and athletes are always concerned of what their coaches think.
Right.
um you know Having a sound mind and being able to rehabilitate the mental aspect can actually help performance. Sports psychologists, while they might not be trained in the counseling elements, they do a ton with coping skills and mental skills and
Mhm.
performance enhancement, and those types of things. So there's certainly some crossover. And, if you're trying to convince a coach why it's important that this patient goes and sees this person, you could always relate it to, well, there could be added,
Yeah.
performance benefits. And the other thing is, we just want to make sure that when we are getting to the point where we're ready to clear an athlete back to sport participation, that they're both physically and mentally ready. Because if they're not mentally ready, they could be just predisposing themselves to another
Exactly.
injury, a concussion, or even
Mhm.
an injury, an orthopedic injury. Because if they're not confident in their movement patterns and being out there and engaging with the game, whatever that is, that's a risk factor for injury. So, having the understanding and being able to explain to athletes and parents that you need to be 100% physically and you need to be 100% mentally for you to be successful in returning to whatever your sport is.
If the athlete is reaching out to that extra resource, for their mental health conditions, is there a clearing process from that provider along with the athletic trainer?
So, yeah, I think it would depend a little bit. Every athletic trainer is practicing under, the direction of their
Mhm.
directing physician, and so there should certainly be conversations between the AT and the directing physician as to what would be the indicators for full return. But I think every case obviously is going to be looked at individually. But a patient who has primarily recovered from their concussion, but maybe they're still seeing a psychologist or a counselor
Mhm.
just for continued, I think they can return. I think they, it's not a, you've got to be done with counseling,
Right.
because we know that a lot of times those counseling sessions are going to, continue, and that is a
Hmm.
good thing. And so it's really, I think just ensuring again that the patient is feeling comfortable. If you're getting them through the return to play progression and they are stumbling at that, I'm not really sure I want to go back to a full contact practice. Um, let's delay that until they feel
Hmm.
confident and comfortable that they're ready to do that.
So, well, I think those are all the kind of questions and topics that I wanted to cover. Is there anything else that you would like to add?
No, I just think, the mental health, and I'm so glad you brought it up because it is a very important piece. It is definitely a piece that has been lacking
Hmm.
within the international concussion guidelines, and unfortunately, the Amsterdam documents are not really going to address it. I will say that it is an addition to the bridge statement that the NATA Foundation is putting together. I actually had the lead on writing the mental health
Awesome.
elements. So there's some great recommendations for athletic trainers that will be coming out in that particular statement, hopefully late summer, early fall. That I think will really help and provide some additional guidance for ATs on how they manage this complicated aspect of
Hmm.
concussion care.
That's awesome. Well, I appreciate your time. Again, thank you for having this conversation with me. I
Yeah.
appreciate it very much. It was nice to meet you.
Nice to meet you too.
Have a good one.
All right. Thank you.
Bye.
Bye.